It is a bright morning and this 4-year-old is glad to have a visit from the social workers. She was born lame, but that's not all she has to live with. She has to contend with HIV, which she was born with.
Olubuto nalufuna ndi musini yafu nengenda okunywa eddagala emulaga ne batukebera ne batujjako omusayi ne batukebera ne bantegeeza nti ndi lubuto ebiseera ebyo olubuto lwali luwezezza emyezi 7.
Rose Nakanjako, the little girl's mother, was 19 and in high school when she got pregnant. It wasn't until her first antenatal visit 7 months into her pregnancy that she learned she had contracted HIV.
Netegeera nti nno nina obulwadde ne bambuuza ani gwe ngenda okubuulira naye mu kiseera ekyo nali sirina gwe neekakasa okuggyako jjajja wange azaala taata kati era gwe nagenda ne mbuulirako kati jjajja azaala taata n'aŋŋamba mugende ndabe omusajja nannyini lubuto omuvubuka kati omuvubuka oyo bwe namugamba saamugamba bya bulwadde kuba nange nali ntidde namugamba nti bamwagala omulaba ng'ebikwata ku lubuto n'adduka ne yeeyongerayo n'embeera ne jjajja paka lwe nazaala.
Her baby's father had abandoned his home, fearing arrest for impregnating a girl out of wedlock. But Nakanjako was forced to join him. She then enrolled in the Makerere University Johns Hopkins Research Collaboration HIV/AIDS study on infants born to mothers living with HIV. Assisted by health workers here, Nakanjako was able to give birth to her baby and received a nevirapine tablet to prevent the child getting infected at delivery. Unfortunately, tests carried out on the child a few days after birth showed the baby was already infected. Nakanjako suspects the opportunistic infections she suffered while pregnant lowered her immunity and made her child susceptible to the virus. The intervention came a little too late. Engulfed by fear, Nakanjako grudgingly disclosed her HIV status to the child's father. The boyfriend's reaction to the news was classic. He blamed Nakanjako.
Kati tugenda okuddayo mu ew'omwami wange ng'alina ka plasta mu mugongo n'ambuuza lwaki omwana bamugya amazzi ku mugongo kwe kumubuulira n'ebyobulwadde n'agamba ye tazaala baana balwadde ba siriimu noonye kitaawe w'omwana kati olwo n'asengula ebintu bye n'andeka mu nnyumba nga ninamu mukeeka gwokka bwe guti gwe nali naluka nga ndi lubuto.
She has struggled to rebuild her life, joining the AIDS Support Organization and the Makerere University Johns Hopkins Research Collaboration with her child. She has also joined the Mamas Club, a local non-governmental organization that brings together women living with HIV.
We come in SEPA because we deal in the community and we deal with mothers and their children, and we do train in PMTCT. We do home visits. We go to the community and do home visits to some of our clients to do follow-ups of PMTCT programs. PMTCT is a big package that we do offer to our mothers because most of these mothers are in the age-bearing group. So we do train them in PMTCT so that they can be able to give birth to HIV-negative children.
Positive living has become her lifestyle choice, and now that she knows more about the prevention of mother-to-child HIV transmission, she's living a fuller life. With her new partner, who is also living positively, they have an HIV-negative child. The child's diet does not involve breastfeeding, but rather infant formula. Nakanjako's story is just one of many stories of Uganda's fight against mother-to-child HIV transmission. A child can get HIV during or after birth. In the first instance, this would happen when the mother's and baby's blood mix. After birth, this happens during breastfeeding. In Uganda, 20,000 children are born with or get HIV after birth. This makes mother-to-child HIV transmission the second highest form of contraction after sexual transmission. Children are the most vulnerable since they are the least likely to access life-saving medicines. This is mainly because they depend highly on the decisions made by adults on the treatment path. Without care and treatment, about 80 out of every 100 of these children will die before their second birthday. In urban health centers like Kawempe Health Center 4, the prevention of mother-to-child HIV transmission services have been running with full support of PREFA, a local non-governmental organization. Now the challenge is not how to run the programs, but the program's dependency on external funding.
On this kind of program, actually, I'm calling on the government to come in and help, not leaving this program for these partners only. Supporting these partners pull out. What will happen to these numbers who are already being supported by this program?
Heps Uganda, also called the Coalition for Health Promotion and Social Development, is a local non-government organization advocating for health rights in Uganda.
So we look at community empowerment, we look at policy analysis, and here I mean health policy analysis and other related policies with a view of informing policymakers whether the laws and the policies are pro-people. If we find them wanting, then we make recommendations and we do follow them up with the necessary government departments.
Along with other organizations, Heps is now running a 3-year campaign to end pediatric HIV and AIDS.
In Uganda, Heps Uganda is working to coordinate all the efforts to make sure that Uganda stands high up there, as it has always been, to eradicate this disease in children, because we know that it is possible. And therefore, as Uganda Pediatric Association, we are leading the effort, pulling resources and working together with other pediatricians to ensure that early infant diagnosis of HIV happens and that early treatment also happens for those children who end up being HIV positive.
The campaign's focus is how to turn into reality early infant diagnosis, access to appropriate medication, advocacy for full funding for PMTCT services, while supporting family-centered approaches in the fight against pediatric HIV.
And we are aiming at reducing infection through mother-to-child transmissions of HIV/AIDS. And what really motivates us is that given the current trends and the current technology in development of medicines to prevent this kind of infection is available and resources are also available. But unfortunately in Uganda, we still have about or over 20,000 children being infected annually through mother-to-child transmissions.
What SEPA wants to do, we want to look at the policy and implementation bottlenecks that are preventing this from happening. We want to see why are medicines not reaching the children and how can we handle that at the policy level.
But the funding from the Clinton Foundation is expected to phase out this year, leaving Uganda with yet another gap in HIV funding. Thus far, SEPA campaign partners at local, regional and international level between September to December 2009 have developed national PMTCT plans. A series of meetings have been convened in this regard and various activities planned to take place in 2010.
You know, when children say they visit a hospital, how does this hospital follow them up in their families? But also at family level, is there support for this pregnant mother? Can somebody support them to go for testing when they are pregnant? But even when they are making a decision to get pregnant, are they aware that they should first of all test and know their status? So you can see it cuts across family, community, and the health institution.
Uganda is a signatory to what we call the Abuja Declaration that obliges all countries that subscribe to this declaration to allocate 15% of their budgets to the health sector. But as we stand now, as a country, we are only allocating 10%. Now, this 10%, what is the allocation for pediatric HIV/AIDS? These are some of the issues that the campaign will be looking at.
If dreams such as this one are to be realized, Ugandans of all walks of life will have to play their part in supporting people living with HIV. And their part is simple: pushing for early infant diagnosis, ensuring access to life-prolonging medicines, and advocating for sustainable funding for prevention of mother-to-child services in Uganda.
This is a campaign that is driven by the Global AIDS Alliance, but our challenge really is to make the government own this campaign, as it were, and to make the people own this campaign, because it has to be people-driven. It cannot be donor-driven or driven by funds, because these funds are soon going to run out. But the truth is, we shall still have people on the ground, and people who need to understand why they must be in this campaign. As in the local terms that people say that tuli mu kintu, we want everybody to be in this kintu, so that it is a campaign that where everywhere you go, everyone is talking about it. Mom, you're pregnant, can you go and get tested? Has your baby been tested? So that it's not only driven by a few people, Dr. Sabrina, SEPA group, etc., but by every single person.
The days when HIV threatened are behind us, thanks to research and all the interventions now in place. The dream of an HIV-free generation still eludes the globe, but now it is within grasp. The onus is on each one of us to play our part in saving these innocent lives.